So, welcome to the Diabetes Care, Diabetologia Symposium. I'm David D'Alessio. I'm the editor of Diabetes. I'd like to welcome you on the behalf of myself and Hendrik Mulder, the editor of Diabetologia, and Stephen Kahn, the editor of Diabetes Care. This tri-journal symposium is a new initiative that the journals have put together last year. The idea was to try to use the expertise of our editorial boards to come up with topics that are both timely and need some clarity. Bring together experts at one of the meetings, either the ADA or the EASD, get them to hash out some key ideas and make a presentation, and then follow that with a paper, a summary statement of where this area ends up right now. We did our first one of these sessions at the EASD in Hamburg. The topic we picked was the microbiome in type 2 diabetes, certainly an area that needed a lot of clarifying. We brought together a dozen experts. They convened for a while, made a presentation, and this paper, The Gut Microbiota and Diabetes, is out in all three of the journals online today. So the first step in this process has gone pretty well, I'd say. I need to thank the Novo Nordisk Foundation, who have partnered with us in this endeavor and paid for it, essentially, given us a grant to do this for a couple more years after this. Today's session is quite exciting. We've picked as a topic heterogeneity in the pathogenesis of type 1 diabetes. I show you here the experts that gathered on Thursday in this convention center to discuss a series of questions about heterogeneity, about what potential mechanisms accounted for that, and would more knowledge in that area lead to personalized treatment or specific pathogenic derived treatment. We had a fascinating session. I think the talks that have been aggregated from that short meeting will be very interesting as well. So without further ado, I'd like to welcome Dr. Leslie to the stage for the first talk today.
Thank you, and I'd like to thank the ADA, the EASD for convening this meeting, and Novo Nordisk Foundation for sponsoring it. I'm going to set the stage for type 1 autoimmune diabetes in a sense of having heterogeneity. And I'm going to sort of indicate you some of the definitions that we consider when we consider heterogeneity. Not just heterogeneity amongst all of you, but also features of diseases in general. Do we call them endotypes? Do we call them clusters? Do we call them fuzzy clusters? Whatever we want to think of. But it's quite important that we understand this terminology, because it will dictate how you view some of the data that's going to be presented to you. Now, type, okay. Type 1 diabetes is seen as a disturbed dialogue between the immune response and the beta cell secretory function. The beta cell seems to be critical in this effect. It seems that it's subject to a variety of factors, including endoplasmic reticular stress, including, interestingly, a raised body mass index, which, if it's raised at 12 months of age, predisposes you to the disease. And recent evidence of exocrine dysfunction also seems to be relevant here. The immune response itself is important, and notably the key antigens involved in that immune response are derived from insulin secretory vesicles, by and large. They include insulin itself, which is found often in very young people, and glutamic acid decarboxylase, which tends to be dominant as an autoantibody in older people. There is a genetic association with both class 2 and class 1 HLA alleles. But intriguingly, the class 1 seems to be less important as you become older. There's a strong age effect in this. We know the immune response develops, particularly in the first 15 years of life, and we know that beta cell function and capacity develops in the first 20 years of life. So there's a strong age-related effect to both of these systems, and we will see that that is played out in a way in the nature of the disease itself. Now, when we think about heterogeneity, you can look around you and you realize immediately that we all have heterogeneity, whatever system you care to think about. Here are some individuals, and if they were to have an endotype, then it would be a subtype which is defined by a distinct pathophysiology. The individual in the center clearly seems to have a distinct pathophysiology. He requires assistance. So those three individuals in the center would be seen as a cluster. But if you look carefully, you'll see that that individual who is on the shield actually rather thinks he's superior to everyone else. He thinks he's the chief. And if he steps down from that shield, he becomes the same as everyone else. So those three individuals in the center become a cluster, and because he has shared red hair with the individual on your right, he becomes a fuzzy cluster. The features he has are not distinct. Now, if he was distinct, and on the shield was actually helping him to stand, to be there, then he would be having a distinct pathophysiology, and he would be known as an endotype. And a lot of our discussion will revolve around this discussion of endotype fuzzy cluster. Now, I'm going to show you some examples of the nature of type 1 diabetes, where there is a genetic and a non-genetic interaction. And I'm going to distribute these results according to the age at which the individual is diagnosed. That is less than the age of 6, greater than the age of 13, and an intermediate level. So if you look at heritability, and this is derived from a recent work of Sofia Karlsson published in The Lancet, where she looked at over 3 million Swedish people, and she found that the heritability was 81% in those who are under the age of 7, and only 56% in those over the age of 13. Again, if you look at some Finnish data for the DRDQ genotype risk, again, the risk is higher, 84% in those who are under the age of 7, as compared with 77% in those who are over 13. Consistent with that suggestion that there's a stronger genetic effect in younger people and a weaker effect in older people, you can look at the identical monozygotic twin concordance rates or discordance rates, where only one twin has the disease. If identical twins are different, are discordant for a disease, then it's very likely it's non-genetically determined. So in our study with Maria Redondo and George Eisenbarth, we found that the twin discordance rate was much lower in younger people under the age of 7, as compared with older people, where there was a very high twin discordance rate, suggesting a strong non-genetic effect. Now, let's look at the autoantibodies, which are seen as an interaction of these two effects, of the genetic and non-genetic effect. Insulin autoantibodies, again, most prevalent, most frequent in those who are under the age of 7. And this data comes from a Finnish study. as compared to older people where the incidence, the frequency of insulin autoantibodies is lower. In contrast, glutamic acid decarboxylase autoantibodies, GADA autoantibodies, are found less frequently in those who are under 7, more frequently in those who are over 13. So there's a clear distinction here between genetic effects and insulin autoantibodies in younger people and non-genetic effects and GAD autoantibodies in older people. Are these representative of endotypes or not? But I want to point out that there is a continua here. If you look again, you'll see that the group in the middle with the intermediate ages have an intermediate level for all of these features. So is this a continua, a form of heterogeneity, or do these extreme levels form evidence of an endotype? Now, I'm going to give you one example where you might consider there is indeed a continua, and that is exocrine dysfunction. We know there is exocrine changes, and it's been described some years ago now that there are changes in exocrine pancreatic enzymes before the onset of type 1 diabetes or with type 1 diabetes. And we now know that if we look at trypsinogen levels in serum, that low levels are actually modestly predictive of type 1 diabetes. Indeed, pancreatic volume declines before the onset of type 1 diabetes, and the volume can be low right before they develop the disease. So here is a study we published recently showing serum trypsinogen levels on the vertical axis, and on the horizontal axis, the sort of ages that of distribution across the age range. And you will remember that the islet, the pancreas itself, develops up to the age of about 20-25, when it grows throughout that period and then stops, then comes to a plateau. So here in dark are patients with type 1 diabetes diagnosed within 3 months, and then those who are in orange are control subjects for these different age ranges. And you can see across the age range, there is a decrease at diagnosis in type 1 diabetes compared with control subjects, with no suggestion really of a categorical difference in those who are, let's say, under the age of 10 and those who are over the age of 20. So is this an example then of heterogeneity? And we'll hear in a minute of propositions that there might be differences which are more associated with younger people than older people. But are they going to be relevant to therapy? Because if you're going to be an endotype, it has to be relevant to therapy. And that is really how this idea of endotypes was introduced in the context of asthma, where there are two different endotypes for asthma which are specifically associated with appropriate therapy. So I'm going to leave you with this before we move on to the next speaker, and leave you with this idea that we know there's heterogeneity, but is it endotypes? Is it clusters? Are they fuzzy clusters? And our next speaker is Raju Mirmara from University of Chicago.
Okay. Let me... All right, lovely. All right, so my name is Raghu Mirmira. I'm at the University of Chicago. And as part of our focus group on Thursday, we talked about heterogeneity across various aspects of type 1 diabetes. And so I was tasked to summarize our discussion as it relates very specifically to the molecular and pathologic features of type 1 diabetes. So these are, oh, I gotta use this. All right, let's try that. There we go. All right, so why is this important? Why molecular and pathologic features, and how do they relate to potential clinical observations? So let's think about some of the things that we know about type 1 diabetes. So pre-diabetic individuals, whom we consider on our staging scheme as stage 1 and 2, we know exhibit islet autoimmunity because they have circulating autoantibodies, but they exhibit varying degrees of glycemic control that progress really at different rates. So if you're type 1, you don't really have much dysglycemia, and if you're type 2, you have dysglycemia, and that dysglycemia can vary depending on what part of that stage you're in, as long as you don't have defined diabetes. So could pathologic or molecular heterogeneity explain that? The second issue is and Dr. Leslie spoke about this, is the appearance of type 1 diabetes at a young age, less than 7, appears to be associated with more aggressive beta cell dysfunction or destruction compared to those who are older, greater than 13. So again, does molecular or pathologic features explain that? And then finally, an interesting feature of type 1 diabetes is that the incidence of type 1 after puberty is greater in males than females. So we're going to go through these, and I'm going to present a little bit of evidence that was presented by 3 individuals, Yuval Dor, Sarah Richardson, and myself, and hopefully try to put this together as part of a discussion that we can have as to the role of the molecular features and pathologic features of the disease. So David Leslie did kind of hint at this notion, right, that there are multiple cell types involved in the pathogenesis of type 1 diabetes. And what I show you here is this sort of feature of type 1 diabetes that involves this interplay of different cell types. So we know that there are healthy beta cells, and then there are beta cells that are stressed. They could be ER stress, oxidative stress, a variety of different stressors have been defined as occurring in these cells, and that may be influenced by the environment, perhaps a viral infection, and that this leads subsequently to communication with the immune system, where the immune system then begins to recognize these stress cells and then subsequently invade the islet, and then you have this sort of vicious cycle. At what point does the disease begin? That's up for debate, but the point here being that we have to consider this notion that islets are part, or at least what we're seeing in terms of the pathology of the islet, is really an important communication between different cell types. And the other thing I want to point out here, which is a feature that will come up in my presentation, is the involvement of interferons. And this is something that has been appreciated more in recent years, that both the type 1 and type 2 interferons may play a very important role, again, in both types of cells. So the first thing I wanted to discuss was a heterogeneity that we can see pathologically. And these were some beautiful studies that Yuval Dor in Israel presented. So what you see here is a recently diagnosed donor with type 1 diabetes from the NPOD repository. And what you could see is that there are 2 islets that are literally next to one another. One looks on the left very healthy with all of the different islet cell types, whereas the one on the right is largely missing beta cells. There's glucagon-producing cells, and then you could see the CD3 positive cells, which are the invading immune cells. So here is heterogeneity in the pathology of the disease. So he asked, is this heterogeneity a feature that is autonomous to the islet or the beta cell? Or is it some aspect of immune system behavior that recognizes one islet versus another? And the way he approached it was looking at interferon signaling. Because again, as I said earlier, we believe that these interferons probably signal very, very early in the disease, perhaps as a result of a viral infection. And what he looked at was a gene, or an RNA editing protein called ADAR. And as long as that is present in the cell, these endogenous double-stranded RNAs that can come from, the genome can be subsequently processed so they don't look like double-stranded RNAs. However, if ADAR is not absent, or ADAR is absent, then these double-stranded RNAs get sensed by a sensor, in this case MDA5 or IFIH1, and that triggers the interferon response and islet inflammation. Okay, so what he did then was ask the question, what happens if we knock out ADAR and then change the whole interferon signaling pathway in beta cells? And what he observed was a phenomenon that looked very similar to what you see in the humans. So this is in the mouse, and you could see that there is this same heterogeneous encephalitis, where on the left you see an islet being invaded by CD445 positive cells, so immune system. And then on the right, a relatively well-preserved islet that seems relatively untouched. So you could probably ask, well, is that because some of these cells recombined and those cells on the right didn't have ADAR? Well, it turns out that, and he did some single-cell sequencing, and what you see is that these are all beta cells, and you could see on the left that this recombination event occurred in virtually all of the beta cells in the pancreas of these mice. But then on the right, when he looked at just the interferon stimulated genes, he found that only a small subset of those beta cells actually expressed these interferon stimulated genes, notwithstanding that ADAR was removed from all of the beta cells. So what does this mean? So this is one potential model, and that is that islets may have pre-existing sensitivities to interferon signaling, that is beta cells, excuse me, may have pre-existing sensitivity, and that when there is that environmental trigger, such as a virus or other stimulus, that these beta cells with very low levels of interferon expressing genes remain relatively non-inflamed and happy. On the flip side, there are probably populations of beta cells where interferon levels are actually higher at baseline, and that when these cells are exposed to a trigger, then you start to see the process of islet inflammation and then the influx of T cells. So this would suggest that there may be heterogeneity inherent in the beta cells, and that might provide some evidence for, or at least some explanation for what we've seen in the pathologic specimens. So now let's move to the second point that I was going to discuss, and that is that there's heterogeneity across ages. So with the young ages showing more aggressive disease, and so this is work presented by Sarah Richardson in the UK. So she asked the question, does maturity of the pancreas at the time that autoimmunity is initiated potentially explain this sort of heterogeneity that we see with the ages? So what is she referring to? So pancreas expansion happens largely in the first 15 to 20 years of life, and there's rapid expansion, as you could see on the graph on the left. And what's happening as the pancreas expands is that there are small beta cell clusters that then presumably coalesce into larger islets, so that we see a much more mature pancreas in later ages, probably 10 and above. And so she asked, if autoimmunity is initiated at this very, very early stage, could that be a mechanism by which the most susceptible beta cells are destroyed and then subsequently do not form the larger islets? And so what she did was she used both archival samples and contemporary samples from a number of sources, and then trained an AI to actually do an analysis of the size of islets, small islets versus large islets, across multiple different tissues, across multiple different individuals. And these were all from healthy individuals. And what did she observe? Well, what she did was bin these islets into islets that contain very few cells, so like bins 0, 1, 2 contain somewhere between 1 to 4 cells or so. And then the higher bins contained much larger islets. And what she observed was that if you look across the age groups that you could see on the far right side, that across all of these age groups, the smallest islets seem to be the most prevalent in terms of frequency. But in terms of contribution, relative contribution to the overall endocrine mass of the pancreas, what she observed was that when you're very young, say fetal 0, 1, primarily the small binned islets are predominant. And then as you age, you could see that they become larger islets. So again, this concept that these smaller beta cells or islets become larger down the road. And you could see that here. And so the presumption, again, based on this was that when you have just a few cells or very, very small islets that aren't fully formed, they don't have the same basement membrane and may be more susceptible to autoimmune attack. And that would suggest that perhaps intervening very, very early when somebody very young, 2 years old, has autoimmunity might be more beneficial than in intervening in somebody who's much older, 13 or 14. Okay. And then finally, I want to present a little bit of work that my lab has been doing, and this is an MD PhD student in my lab who's been interested in studying sex differences. So if you look across different autoimmune diseases, one thing that's unusual about type 1 diabetes is that there isn't much sexual discordance, about 50-50, maybe a slight leaning towards male. But that really stands in stark contrast to Sjogren's, Hashimoto's thyroiditis, lupus, etc. But then, and this is old data, and it's been replicated a number of times, but I'm presenting the older data. You can see that roughly between 12 and 15 years of age, if you look at incidence of the disease after that age, that there is a discordance, that males tend to have a greater incidence of disease compared to females. So we asked the question, could this be something that's inherent to the beta cells as opposed to the immune system, which is, something that we see more prevalent with female sex? So the way we did this was we looked at samples that were actually data sets that were already published, and this was published by Carmela Evans Molina's group and ours in collaboration a number of years ago. And there what we did was we took male islets separately from female islets. They were all treated at the same time with either no treatment or with a condition that would mimic type 1 diabetes with pro-inflammatory cytokines. And then we looked at gene expression patterns by bulk RNA sequencing. And if you look at this graph here, you could see that in the presence of cytokines, there's a dramatic shift in gene expression profiles that seem to correlate primarily with cytokine treatment or no cytokine treatment. However, if you then look at males and females, you could see that they separate further, that males separate separately from females. And this raises the interesting possibility that gene expression patterns in these islets would be different based on sex. And so when we then dug a little deeper and looked at the gene expression changes, quite remarkably, we found that there were more than almost 3 times as many genes that changed in males compared to females. Most of those genes in females overlapped with the males, but the ones that were male only showed, intriguingly, a very separate kind of signaling. So they showed more inflammatory signaling, as you could see, cytokine receptor interactions, and then interestingly, a very strong component of interferon signaling, the JAK-STAT signaling pathway. These were the most prominent. There were some other interesting features here that I'm not going to discuss, but nevertheless, it would appear that there is a more sensitive response in male beta cells compared to females. So how do we put all of this together? I think there's some concepts that emerged from these 3 talks. That's one concept is of beta cell vulnerability, that there may be inherent differences in different populations of beta cells to inflammatory signaling, that perhaps environmental triggers, particularly viruses or other infections that drive the interferon response, may be crucial in sort of triggering these beta cells. And then the immune system. This is important as well, because without the immune system, you wouldn't get type 1 diabetes, that the immune system may differentially target certain beta cells that are more sensitive compared to the more resistant beta cells. And that could explain the different features that I talked about, the heterogeneity in islet pathology. It could explain the heterogeneity in disease onset. So are these early single bin, low bin numbered beta cells that are just few in number, are they more sensitive to autoimmunity because they have greater interferon signaling? And then, of course, gender disparity with heterogeneity. So these are some issues that we could discuss in our panel a little bit later. So with that, I'm going to turn this over to our next speaker, and I think it's Maria. Is it? Thank you.
All right. So, thank you for even opening for me. So, thank you very much to the organizers for inviting us to discuss these interesting topics and then to present a summary of what we discussed today. So, so the previous two speakers have set the stage talking about how in type 1 diabetes we really see different subsets. It is not clear where they are distinct, whether it's really a spectrum, whether we can find some pathogenic basis for that. And then Dr. Evans Molina will talk whether we can use that for treatment. So my task is to summarize the findings, the observations that were presented by Dr. Steve Rich and by Dr. Oki Lermark and by myself regarding antibodies and HLA. So we know that definitely antibodies is what, the number of antibodies in particular, is what we use for the staging system where we identify people who are at a certain risk which may warrant intervention. And HLA, we've known for a long time how it contributes to the risk of type 1 diabetes. But there's more beyond those two items. So here we took individuals at risk for type 1 diabetes. These were participants in TrialNet, so autoantibody positive relatives of individuals with type 1 diabetes. And we used a semi-supervised clustering analysis, taking as the outcome progression to type 1 diabetes. And we identified at least, in particular, 6 clusters of individuals who have distinct characteristics that are different from other groups, but all of those have a similar risk. So basically within each cluster, individuals have similar risk of progression to type 1, but they can have very different characteristics. And in particular, we saw that the presence of insulin, the IA2 antibodies, which has been for a long time known to predict imminent progression to type 1 diabetes, constitutes a very powerful clustering variable. And those individuals, even when it's the only antibody they have, the risk of diabetes is very high. Age has been mentioned before, is also a very powerful variable that clusters individuals according to the risk of progression to type 1 diabetes, and so is C-peptide and glucose. We were able to confirm these findings in a different independent data set using the DPT-1 study, which are also individuals who are autoantibody positive at risk for type 1 diabetes. So one of the implications of this finding is that the current staging system, which is very important because it has allowed us to put a framework to prevention in type 1 diabetes and is very well accepted by multiple parties that are involved in that process. But it is really becoming clear that it is too simple for the knowledge that we have today in terms of how we can identify and assign risk of progression in individuals. So one of the beauties of the staging system is the simplicity. It has to be something that is usable by the clinical researchers and today by the clinicians. So we need a system that is user-friendly. But today, the tools that we have allow us to have a really complex algorithm clustering structure behind the scenes, but with a user-friendly interface. And that's what we've been trying to do with a type 1 diabetes risk calculator that puts in the vaccine all of the complexity, all of the factors that we know that can allow us to have more precise estimation of type 1 diabetes risk, but yet have that simplicity that we need in the clinical research and the clinical arenas. And then the other consequence of this is that there are individuals with atypical characteristics who maybe are older, have higher BMI, have single antibody positivity, and then they do have also that risk of developing diabetes, and maybe they have different pathogenic mechanisms that we can start thinking about. And I will be able to present a little bit of that at the end. So this is a slide shared by Dr. Oki Lermark and by Kendra Vihik has been working on this for a number of years as well. So this represents children followed by the TEDdy study, which, as you know, follows children who are genetically at risk for type 1 diabetes, but are followed from birth. And you can see how the first time that they are identified as autoantibody positive, about 41% are positive for GADA, 39% for insulin antibodies, and then you have a number of other combinations that are possible with that at the very first time that are identified as positive. But it is important to recognize that that seroconversion to insulin antibodies as the first antibody happens very early in life, and those individuals have a very high risk of developing a second antibody, so they are now multiple autoantibody positives, and then go on to clinical type 1 diabetes. And those are the big peaks that you guys see very early in life with that conversion from insulin antibodies, I think that's the gray line, to multiple antibody positivity. On the other hand, with GAD positivity, you can have seroconversion along the 15 years of age that the TEDdy study has been following children, and that continues along those years, is pretty stable, pretty flat, and it gives that risk of progression to multiple autoantibody positivity and islet and clinical diabetes along those 15 years. So with insulin antibodies, it declines. It is confined to those first years. With GADA, it continues at least for the 15 years that we have good data on. And then on the second chart, you have the individuals, the children who remain single autoantibody positive, and there's clearly much less difference between that GADA and insulin antibodies. So the previous speakers have been talking about a number of risk factors, mechanisms that we think that are important in type 1 diabetes progression, such as infections and the antibodies and the age. And here you can see how, if we look at this paradigm of GADA first versus insulin antibodies first, those who have the highest likelihood of developing GADA first tend to have HLA-DR3 DQ2. It is associated with infection by enteroviruses. There's association with protective with some of the insulin genetic variants and some other non-HLA genetic variants that are important as well. And then with older age. On the other hand, people who develop insulin antibodies first are more likely to be younger, to have DR4, DQ8, to have rhinovirus infection and upper respiratory infections. And this data comes from the TEDdy study and was presented by Dr. Oki Lermark on Friday. So, okay, there we go. So in the TEDdy study, they were even able to identify 3 tracks of progression to clinical type 1 diabetes. On the first track, the purple line, you have the people with the lowest risk of progression to type 1 diabetes. Those are the children who develop GADA first. And then in the intermediate line, you have the children who are first identified as insulin autoantibody positivity. And then finally, on the children with the highest risk are those who, on the first time that they are screened, they already have multiple autoantibody positivity. And this is data coming from over 24,000 children across different cohorts for the natural study of type 1 diabetes. Another very important part of heterogeneity in type 1 diabetes comes from ancestry. Until now, it has been really difficult to study this because most of the studies are limited to European ancestry individuals. However, there's been a huge effort that is still ongoing at identifying individuals at risk for type 1 diabetes or with type 1 diabetes from other ancestries. And that has really allowed an explosion on studies trying to understand this. And this slide was, actually was much longer. This is just a very brief summary, was presented by Dr. Steve Rich on Friday. And here you can see the type 1 diabetes genetic risk scores for the different ancestries and how they perform on the different genetically inferred ancestries. And one of the consequences of this slide is that we are still trying to develop, to understand whether we will be able to use a unique genetic risk score, cosmopolitan genetic risk score that can work well enough across the different ancestries, or whether we will need to use different scores that are ancestry specific. And I can tell you that talking from, with different people who work on this, that's still an ongoing debate. It is not very clear. Obviously, it would be easier to have a score that can work across ancestries, but might not be possible. The jury is still out, but it's definitely a very interesting topic. Of course, there's other strategies that can be used of using local ancestry and in a way incorporating this important variable. But as we try to incorporate genetics into the predictive model for type 1 diabetes and for example, for classification of diabetes, we will definitely need to figure this out. And then finally, just one slide on another aspect of heterogeneity that I think is important. So we've been talking about heterogeneity within type 1 diabetes, whether we call that endotypes or other is still unclear. But I think that another important part of heterogeneity comes from overlap with type 2 diabetes. And let me walk you through this slide. So this grid represents what we call the metabolic heterogeneity of individuals at risk for type 1 diabetes. These are autoantibody positive relatives who do not have diabetes yet, and then in this grid we represent on the x-axis C-peptide AUC coming from OGTTs, and on the y-axis glucose AUC. And this system was devised by Jay Sosenko from the University of Miami, and we show that these 25 cells are really very different in terms of genetics, autoantibodies, and metabolic markers and demographic markers. But what you can see is that individuals with the highest C-peptide, who are on the column more to the right, and then in the upper rows with the highest glucose, those are the individuals with the So individuals with the lowest C-peptide, so on the A column, and then the highest glucose, so on the 5 row, those are the individuals, the relatives, with the highest risk of progression to type 1 diabetes. And on the other hand, those with highest C-peptide and lowest glucose, which is in the lower right corner, those have the lowest risk of progression to type 1. And sure enough, the type 1 diabetes genetic risk score aligns with that. So we have the highest risk score in the upper left and the lowest type 1 diabetes genetic risk score on the lower right? That is as expected, and that means that the genetic risk score that was developed by Richard Oram and his group works very nicely. On the other hand, on the right, you have the type 2 diabetes genetic risk score, and you can see that there's also a gradient. So these autoantibody positive relatives have a difference in terms of their type 2 diabetes genetic burden. And those who have the highest C-peptide on the right column, the letter E, have the highest type 2 diabetes genetic risk score. And we think that this underlies many of the metabolic differences that we see in this population. And of course, some of these individuals will go on to develop what we call type 1 diabetes because they have positive antibodies. But it is becoming more clear that there are type 2 mechanisms that are intervening in that progression. And this is shown with the genetic risk score, but you can do a very similar graph with BMI or other typical type 2 pathogenic markers. And that's all for me. Thank you very much. And I would like to present the next speaker, who is Dr. Carmela Evans Molina.
Okay, great. I too would like to echo my thanks to the Novo Nordisk Foundation for supporting this workshop, and then also to the editorial staff and leadership at Diabetes, Diabetes Care, and Diabetologia. I think it's really unusual to be able to spend a whole day with expert colleagues like the ones that are presenting here and the others who are in the audience, to be able to really dive into a complicated topic like heterogeneity in type 1 diabetes. So I think that was a real pleasure, and it's nice to see these talks come together to try to synthesize some of the topics that we discussed in the workshop. So I'm going to change gears and talk about how heterogeneity might impact our clinical trial efforts in type 1 diabetes. And I think that everyone is likely aware that we're in a very exciting time in type 1 diabetes therapeutics with the approval of teplizumab as the first disease-modifying therapy. And this was approved in November of 2022 and has really changed how we're thinking about stratifying individuals at risk of type 1 diabetes, identifying them clinically, and then treating them potentially with this agent. And the approval of teplizumab was based on studies performed in the Type 1 Diabetes TrialNet Consortium. We had input from people from different Type 1 diabetes networks in the workshops to be able to think about how heterogeneity impacts efforts in these consortia. But the trial that led to the approval of teplizumab really tested the impact of daily infusion for 14 days of the drug in individuals in stage 2 type 1 diabetes. It was a very small trial, 44 in the teplizumab treated group and 32 in the placebo group. But when the original trial results were reported in 2019, there was a median delay to stage 3 type 1 diabetes by about 2 years. And this analysis was updated by Emily Sims in 2020 and showed extension of the delay by about 32 and a half months. So this is really, I think, a remarkable achievement in type 1 diabetes, but we still have a long way to go. I think one of the biggest challenges that we have to acknowledge is it took us 30 years to get to an approval of a disease-modifying therapy with this particular class of agents. So the first mouse studies began testing teplizumab in 1992, and then we didn't begin enrollment into the TN10 study, which led to its approval until 2011, with the trial results being reported out in 2019. So this is a very long trajectory for drug approval. What we would like to have in type 1 diabetes are multiple therapies. So really a big gap in the field, and a goal that we should all have is how can we design trials that take less time to complete, that enroll faster so we can have answers on whether they're able to delay disease progression. So I think that heterogeneity has a really important role in helping us understand type 1 diabetes progression and help us inform clinical trial interventions. Certainly, Maria has hinted on the impacts of metabolic heterogeneity during disease progression, and I think that this has really important implications in our trial design. There's likely that baseline immune signatures can help us identify people who are potentially primed to respond to disease-modifying therapy. I won't talk about that so much in my short presentation, but what I will discuss are some really exciting results from people like Steve Rich, who participated in the workshop, and Maria Redondo, who spoke before me, really looking at the impact of genetic variation and how that influences therapeutic heterogeneity. And then I think that we, as hinted at by David in the opening talk, a real cautionary note about the language that we use when we're discussing topics like heterogeneity and endotypes. So one way that we can understand heterogeneity in clinical trials, which is a challenge in type 1 diabetes because our trials are small, is to do subgroup analyses. And I want to just highlight a few important subgroup analyses that have been done as part of the teplizumab study. These were pre-specified. The caveat, of course, is that you're looking at very small numbers of individuals when we make these assessments. But nonetheless, a really important finding of that trial is that responders quite to our surprise, were more likely to have a lower C-peptide. So if you divided the study group into those with a C-peptide area under the curve below or above the median, you can see by the Kaplan-Meier survival curves on the right that those that had an AUC below the median had a much better response rate. And again, this was a surprising finding from this particular trial, and it's probably opposite of what most of us would have predicted. Now, we've had an opportunity to observe a similar effect in the oral insulin study that was performed in the TrialNet consortium as well. This trial enrolled persons with type 1 diabetes, relatives of persons with type 1 diabetes who had at least 2 autoantibodies. They had to, by trial inclusion criteria, have an insulin autoantibody, and they had normal glucose tolerance, which is somewhat different than the teplizumab study. Those individuals all had dysglycemia. So individuals are randomized to receive 7.5 milligrams of oral insulin. This was a rather large study, and then again, the primary outcome was time to diabetes development. Now, if you looked at the study group overall, there was no effect of oral insulin. This was a negative study in the overall study group, but there was a pre-specified secondary stratum of individuals who had a low first phase insulin response. So these were people that had the lowest beta cell function that were randomized to receive oral insulin. And again, a surprising finding in this secondary stratum is that individuals with this low FPIR had a response to oral insulin therapy. Again, the caveat, this is a small subgroup, but it's nonetheless, I think, an intriguing possibility that has helped inform a working model that we're now using in TrialNet to develop future trials and current trials, actually. So if you think about this idea that in both the teplizumab study and the oral insulin study, the people who had worse beta cell function among the study groups had a better response, that leads us to potentially hypothesize that there is a window of disease progression where there's accelerated and active disease, and it's during that time period that people may be really primed to respond to a therapeutic intervention. Now, we've used things like dysglycemia, which is the definition for stage 2 type 1 diabetes, in trials like the teplizumab study, but again, we saw a quite heterogeneous rate of progression amongst those study participants. So one of the ideas that we've been really using as a framework in TrialNet is to better define this period of accelerated disease development or active disease. So, for example, in the ATG prevention trial that's being enrolled currently, we are enrolling individuals who have 2 or more islet autoantibodies, and they meet stage 2 criteria, but they have at least one additional high-risk marker, being either an elevated hemoglobin A1C, DPTRS, which is an aggregated risk score, or index 60, which combines C-peptide and glucose measures. So the idea here is that we can create a more homogeneous study population with a more cultivated or identified risk of progression, and we can look across the time horizon, perhaps estimating that they might have a 50% risk of progression within 2 years. This may ultimately help us identify more responders, but it can also shorten our trial designs. So then finally, if we've covered some metabolic heterogeneity and how that might impact trial design and results, what about genetics? And I think this is a really exciting area that people like Steve Rich and Maria are really leading the way. And I want to highlight 2 really, I think, intriguing pieces of data from their groups that were shared in the workshop. So this is first looking at genetic analysis of the participants in that TN10 or teplizumab trial and identifying if there are any variants that might have influenced the trial outcome. And so Steve's group, and this data was presented by Dr. Michalik and his group, his group was able to analyze whether there were differences in teplizumab treated individuals versus placebo-treated individuals, and then also looking at variations in only those who were treated. And so some, I think, intriguing results suggesting that there are indeed variants that regulate pathways like inflammation or T-cell mediated cytokine production, thymic TCR signaling that could have impact on therapeutic efficacy in trials. Now, I think a really interesting hit that he identified is that there is a variant in a gene that regulates enzymatic metabolism of drugs. And so I think this is a really important, perhaps, lessons for us to think about in trial design, the impact of pharmacodynamics, especially when we're treating individuals across a wide age span. And then finally, I would just highlight some exciting data from Maria's group. She's gone back to that oral insulin study that I highlighted at the beginning to try to understand if there are genetic variants that might have influenced response. And she's focused specifically on that secondary stratum group of individuals, the ones who showed a response and had a low FPIR. And one really intriguing finding from this analysis is that individuals who did not have a disease-promoting variant in GLIS3, which is an important gene in the beta cell that's known to play, variants in the gene have an effect on risk of type 1 and type 2 diabetes, and then GLIS3 mutations have been associated with neonatal diabetes too. So the observation from this analysis is that those without those disease-promoting variants are the ones that really drove the response in that secondary stratum in the oral insulin trial. So I think this is important, and it shows us, I think, the impact of variants that might affect beta cell function when we're looking at trial results. Now, we had a long discussion in the workshop about how you might use genetics to randomize in trials. I think there are many, many challenges associated with that, but certainly these post-hoc analyses, I think, can be informative. So I'll just summarize by saying I think we have a lot of information that metabolic heterogeneity it may certainly impact optimal timing of disease-modifying interventions and likely plays a role in responder, non-responder status among our trials. I think there's really intriguing data coming out now that says genetics may help us identify treatment responders. I haven't had time to discuss some of the emerging information about baseline immune signatures, signatures of exhaustion, et cetera, but I think these are going to be equally important. And then finally, I think a point that David made at the beginning, it's important to be very precise in our language about heterogeneity. And I think we spent a lot of time thinking about this in the workshop. Really what we're describing as heterogeneity, the term that has been used a lot around endotypes implies that we have a therapy that can be targeted to a particular group, and we're not there yet in type 1 diabetes. So with that, I will just end and say thank you again to the Novo Nordisk Foundation, and then invite Jeffrey Millman up.
All right, good afternoon, everybody. My name is Jeff Millman. I do research at Washington University in St. Louis. I'm going to be speaking on behalf of myself and Mike Rickles on cell therapy and the heterogeneity associated with that for type 1 diabetes. So cell therapy, and those were our disclosures. Cell therapy has proven to be a effective treatment for controlling blood sugar levels in patients with type 1 diabetes. The way this is commonly done currently is that islets are isolated from the pancreas of deceased donors and infused into the liver, with patients also being given immunosuppression to avoid rejection of these cells. And when it works quite well with patients enjoying good blood glucose control. However, there is a lot of heterogeneity embedded in the use in cell therapy. What I'm going to show here is a study done by Dr. Rickles' team, which was presented during the poster session on Saturday, showing heterogeneity in the engraftment of islets in several patients that they were looking at. So in this study, they first defined in these patients receiving islet transplantation, the functional beta cell mass that these patients ended up with by comparing the insulin secretion in these patients to match the non-diabetic controls, with those non-diabetic controls being considered to be 100% functional. And you can see that some patients, were at or approaching 100% functional, but a lot of these islet recipients had, quite a range in the functional beta cell mass that they were able to achieve with transplantation. And through looking at the data associated with these patients, they were able to determine that at least a 20% functional beta cell mass was necessary for insulin independence, but achieving at least a 40% insulin functional beta cell mass was a much better predictor of patients coming off of insulin. However, with time, likely due to susceptibility of the beta cells to autoimmune and alloimmune mechanisms, there was a progressive loss in functional beta cell mass that resulted in patients needing to resume insulin therapy. But this in itself was highly heterogeneous, with there being multi-year variations in when the patients actually needed to resume insulin injections. And this perhaps could be improved upon if we were to have biomarkers that could predict when grafts are failing and before patients actually need to resume insulin therapy. Variation in beta cell mass also had a relationship with glycemic control in these patients. So overall, most of these patients were able to achieve 95% time in range for their blood sugar levels. And through this analysis, Dr. Rickle's team found that having at least 20% functional beta cell mass could predict the elimination of hypoglycemic events. And achieving at least 40% functional beta cell mass would be a good predictor of patients spending at least 95% of their time in range for their blood sugar levels. And so what this teaches us in the world of cell therapy is that we want to aim to achieve at least a minimum of 40% functional beta cell mass within patients in order to best ensure insulin independence, good time in range, and also avoidance of hypoglycemic events. And this could be helped by having a more consistent cellular product to put into these patients rather than as an alternative to the heterogeneous islets that we get from deceased donors. And so the topic that we ended up discussing at the forum meeting on Thursday were stem cell-derived islets as being this consistent source of islets. So the data here is from the ongoing Vertex Pharmaceuticals trial, for which we heard a really amazing update about on Friday. Just to summarize real quick about this, that with now using stem cell-derived islets rather than cadaveric sourced islets, patients now are able to achieve a really good time in range, about 95%. These patients are also able to have a good restoration of their reduction of their HbA1c, and patients are able to have large reductions in their insulin need, including 7 patients no longer needing insulin injections. Though, of course, this is still being done with in combination with immunosuppression. So given this context, I want to take a step back and think about what sources of heterogeneity do exist in stem cell-derived islets, and how do we think about that in terms of improving and defining new therapies. So going back to basics here, the way that these stem cell-derived islets are generated is by treating human pluripotent stem cell lines with specific combinations of chemicals and growth factors in a very specific temporal order in order to generate stem cell-derived islets. But one thing that is really annoying as a person who works in this space is that different cell lines with different genetic backgrounds oftentimes need to have some changes in the actual differentiation protocol in order to be successful in making stem cell-derived islets. In other words, there is heterogeneity in how different cell lines behave and respond to differentiation cues that need to be accounted for when you're trying to generate stem cell-derived islets in the laboratory or through a manufacturing process. Even if you're able to overcome that and generate stem cell-derived islets, there's heterogeneity in the characteristics of the final islet cells, depending on which cell line you generate them from. So on the screen here, I have just some bright field images of the clusters generated at the end of the differentiation for many different cell lines, just showing qualitatively that even just how the clusters look, particularly in terms of what size they are, can vary depending on which cell line you are working with. The composition is also different, and on the right here I have quantification of the fraction of cells that were beta cells across multiple different cell lines, showing roughly a twofold range in terms of what was achieved with these cell lines. It's not just the beta cells, also the glucagon and somatostatin expressing cells can differ in terms of their composition within the islets, and some of them can also differ in terms of if they are polyhormonal or not. Perhaps maybe more important for cell therapy, the function of these cells can vary as well, depending on which cell line you are working with here, both in terms of the amount of insulin these cells are secreting under basal conditions, but also in terms of their glucose-stimulated insulin secretion in vitro assays. So I've been spending a lot of time talking about cell lines, but also the actual protocol that you're using has a real big impact on the characteristics of the final stem cell-derived islets that you are able to produce. And so to illustrate this point, I have this non-diabetic donor iPS line for which my team had given it a protocol we published in 2019, comparing it to a protocol that we published the year later in 2020. And you can see that just taking the cell line, giving it the 2019 protocol, we're able to get cells that can secrete insulin, but it's a really poorly functional insulin secretion response compared to the deceased donor islets we're using as a positive control here, as opposed to just like the protocol that we had published a year afterwards was actually quite effective in terms of getting a very strong insulin glucose response from these cells. And so kind of putting this all together, we have several different sources of heterogeneity in terms of stem cell-derived islets, many different ways that heterogeneity can manifest in stem cell-derived islets. And I think one of the goals that we have from a bioengineering focus is that we have a design goal that we would want to minimize heterogeneity in order to increase the value that these cells have for type 1 diabetes cell replacement therapy. And we, on the Thursday meeting, we talked about a few different ways that this could be achieved. One of the easiest ones is to lock in the specific cell line and differentiation process combination that you are interested in, since those are fairly large sources of variation, and that would enable you to have much more refined, standardized, and reproducible protocols for actually ensuring consistent production runs for the cells that you're trying to make here. Also, with the goal, there's a goal of trying to enhance the maturation of function of these cells with increased function likely going to result in faster cures for patients with fewer cells, and also overall just being less reliant on maturation that is currently necessary after engraftment, with the Lisa Vertex trial showing us that it takes about half a year before these cells are fully able to function within patients, which is also probably another source of heterogeneity in terms of clinical outcomes here. The last area that we talked about was scalability and automation, that if we could, with these two things together, we could ensure consistent implementation of the actual differentiation process, which would result in consistent cell culture conditions, which would hopefully result in consistent stem cell-derived islets. And having large batches of cells would minimize batch-to-batch variation that could occur. Another angle of interest here is patient heterogeneity in terms of cell therapy that is kind of implicit in the way that cell therapy is being done right now for type 1 diabetes. That currently only a very small subset of patients are eligible to receive an islet cell therapy. And that's because of the current need to combine these cells with immunosuppression. As opposed to, we would really prefer to have these cells be available for a large number, if not all, patients with type 1 diabetes. And that would necessitate no longer having immunosuppression, but instead having some form of an immunoprotected islet instead. So there's a lot of different ways to do this. Just for the sake of time, I'm going to focus on one of the new kids on the block for achieving this, which is gene editing to generate hypoimmune islets, which in the study that I'm showing here, these cells had their HLA knocked out and CD47 overexpressed in order to address issues of rejection for both the adaptive and the innate immune system. And in this situation, we were able to take these cells, transplant them into humanized mice that were able to avoid being rejected versus, which is the red lines there, versus the normal unmodified cells, which were rejected after a couple of weeks inside of these mice. In other words, towards the goal of producing a universal cell that maybe can cut through the heterogeneity that exists in patient populations in order to make it more accessible for patients. And then the final thing, just to tie it back to what the other speakers were talking about here, is that these cells are not only useful for therapy, but they're also useful in terms of addressing issues of patient heterogeneity that have been discussed by everybody else here. And there's an idea in the field that is not technically feasible right now, but something that we're striving towards, which is if we can get a large number of iPS lines generated that represent the diversity and heterogeneity transit in the type 1 diabetes population, we can then make these into beta cells and study aspects of genetics, environmental factors, immune cell interactions that could give us new insights into why type 1 diabetes exists in the first place. So with all that said, I appreciate your attention, and I believe we are going to move on to the panel discussion. Thank you.
So, I'd like to introduce myself. I'm Henrik Mulder. I'm the editor of Diabetologia. And I'd like to invite all the speakers to come up to the podium and participants who were part of the workshop. So please come up to the stage. And the idea here is to have some concluding discussion to see whether we can further illuminate some of these issues that were discussed. And this is open for discussion, so please, anyone who has a question to the speakers, to the participants, feel free to come up to the microphones, identify yourselves, and please be brief when you ask your questions. So now that everyone is seated, before any questions, I'd like to extend my gratitude to all of you, because you've been working very hard. There's been lots of activities going on behind the scenes that you are not aware of. You're seeing the end product of a 5-day, very intense effort. And I'm impressed by the way that you have been able to interact and create this joint expression of what the problems are, what are the promises of heterogeneity in type 1 diabetes. So thank you very, very much. And this is not the end, because we're not letting you off the hook entirely. You will also prepare a summary article that will be published simultaneously in the 3 journals. So now, questions for these outstanding scientists. Don't be shy. David.
Can I ask a question of Carmela? Carmela, if we think about beta cell dysfunction, there seems to be some heterogeneity in beta cell dysfunction, and there are drugs available to promote beta cell dysfunction in the context of type 1 diabetes. We saw that those people who had a high C-peptide seemed to respond less well to immunotherapy. Do you think it is possible that those who have a high C-peptide would respond better to beta cell support therapy?
I think it's an interesting question that I think opens the discussion around combination therapies, which is something the field feels very deeply that we should be moving towards. The question always then is what type of combination therapy, and it would be wonderful and lovely to have something that is beta cell supportive, as you said. I'm not sure. I might predict the opposite, that maybe you would have a more enhanced response if you gave people with a low C-peptide or more severely dysfunctional beta cells, something that, in addition to modulating immune function, would also be beta cell supportive. I think maybe Maria also would bring in the idea that some people are likely to have some combined insulin resistance, and that's something that we don't talk about or address in our trials. But I think that would be my prediction.
But what about GLIS3? That this interesting GLIS3 association, that might suggest that one would be better than the other.
Yeah, I think that that was, something that Maria shared that I think is a really, really exciting finding. If you look across a normal population, the magnitude of the distribution of beta cell mass, what you kind of bring to the party, is about a 4-fold distribution. So I think that particular finding about GLIS3, I think, really potentially highlights that when we identify people with autoantibodies, we really don't know where they are in their disease progression, and we have no idea where they started at in the beginning with regard to their beta cell function and their beta cell mass.
So we have a question here on the right side.
Matt Orland, Nevada. Maybe 20 years ago, two individuals with type 1 diabetes met each other in my waiting room and decided to get married, have a family, and asked me at the time what was the likelihood that their offspring would get type 1 diabetes. Back then, that was kind of hard to find, and I imagine we've learned a lot more since then, but my question is a little bit more specific. Have we looked at heterotypes? I never would have thought about what was the age of onset of one of the two versus age of onset of the other to determine whether heterotypic differences, if they really exist, might be explored when people with type 1 diabetes mate.
So the question, I'm sorry, let me make sure that I understand, is whether the risk with two parents with type 1 diabetes, is that what you were asking?
Two parents with type 1 diabetes, what is the likelihood of their offspring having type 1 diabetes? It seemed to be additive 20 years ago. I'm sure we know a lot more now. But the more interesting question in light of their discussion is, if their diabetes is a diabetes with heterotypic difference, would that affect what we might see in offspring and how we might counsel individuals with type 1 diabetes, number one. Number two, what can we learn from this?
Okay. So you pose a very difficult question. I will try to give you the best answer I can. So I think that, number one, I think that there are many factors that affect the risk of diabetes in the offspring or in a given person. And it is clear that we need to use all of the tools that we have to put that together, right? So just family history is not enough. We need to include age, we need to include genetics, immunology, biochemical markers, and then the interaction among those markers. So we really think that we need to use that cluster analysis and advanced statistical methods to come up with models where we can input that information and give you a straight answer. I think that so far we've been relying on the staging system, for example, where it's really difficult to give a straight answer, right? So we need to give a percentage and a horizon. The risk is X% at this many years. So I think that we need to have better tools to answer that question. I don't think I can give you a straight answer. We actually have a beta version of a type 1 diabetes risk calculator where we can input your data and try to give you an answer, right? The other part that you asked, whether the different endotypes and how would that impact, I think is very interesting. Anecdotally, I have patients who have classical type 1 diabetes from very young onset, whose mom, in this case, actually two patients, have LADA. Late onset diabetes in adults, right? So I think that what happens is that at the end of the day, people develop diabetes through different mechanisms that can combine and interact. So you can have, endotype 1, if we want to talk about endotypes, endotype, another element of endotype 2, then the elements of type 2 diabetes, and all of those at the end will combine, right? Particularly, I'm interested in the overlap and the combination between the type 1 and the type 2 mechanisms. And then I think that adding even monogenic variants, some people have those, and it's becoming more clear in the type 2 diabetes field, for example. So I think that all of them will combine. And I know I'm taking very long time.
So I have a
But it was a difficult question.
I can perhaps, I don't know if it comes across, I can perhaps give a much simpler idea that I have, and that it's important to remember that type 1 diabetes is due about half of genetics and half from other factors that we really don't know. So having a genetic predisposition is not destiny. It doesn't mean that you will, if you have a predisposition, a high type 1 genetic risk score, it doesn't mean you're guaranteed to get the disease. If you have a low type 1 genetic risk score, it doesn't mean you're always protected. But it is partial genetic and partial other factors. Genetics doesn't change very quickly over time. It takes hundreds of generations to really increase risk scores across allele frequency patterns across populations. And so what we see in terms of increasing rates of type 1 diabetes is probably due to non-genetic factors. And so you can look at environmental factors, and whether that means stress or whether it means exposure to chemicals or foods or things that are put into the things that we consume that we don't know about. So I would say that, the old classical estimates of, the risk in a general population being about, 1 in 1,600 to 1 in 1,000, and you have maybe an 8% risk if you have an affected sibling, also affected parent, but the parental difference is higher if your father's affected than the mother's affected. These are all sort of general concepts, and the increase that we see in some populations is probably not genetic. So I think, as Maria says, it's a complicated response, but I think that until we figure out how to actively determine who's at risk, how do they progress from stage 1 to stage 2 to stage 3, and then how we can decide how the beta cell is exposed to factors. In many ways, it's like real estate. It's location, location, location. And the location is where the beta cells are being attacked in the pancreas and how they respond to that attack. So it is a very complicated situation.
Through the years.
Definitely very complicated. So I have a question for Flemming Posiot. In order to monitor heterogeneity, we need biomarkers. Could you please comment on this issue?
I couldn't really hear you, Henrik.
Biomarkers and heterogeneity.
Biomarkers. Okay, so how to monitor development or heterogeneity? Yeah, I think, it was touched upon a little bit in all the talks that we have a huge need for novel biomarkers to characterize heterogeneity in the different stages, whether it's on beta cell function, whether it's on the immune system, whether it's on progression rates. I think that's interesting when we're talking about, now we're talking a lot about genetic markers, which are kind of very static markers, which doesn't really change or doesn't really capture changes in your risk for developing diabetes. So I think there's a big need for these novel biomarkers to follow disease progression.
Maybe Chantal Mathieu has something to say on the topic.
Yeah, I was in the other room giving a talk on precision medicine in T1D, and that's to me where the big advances are through our multi-omics analyses. And Flemming was also part of, for instance, the European project in ODIA, where now the first publications are coming out that in this, we now understand that once you have 2 or more types of autoantibodies. You have autoimmune type 1. But what we don't understand is the progression speed, how to identify that. And we agree this is heterogeneous. Some people progress in weeks, others progress over 20 years. And we have some clinical biomarkers like age, or if you can call it clinical, also the type of antibodies or the titer of antibodies or the affinity of antibodies that give us a hint how close you are. Metabolic hints like OGTT abnormalities, proinsulin levels, etc. But now we do have omics signatures that are coming out. And I showed data on proteomics signatures, on gene signatures, on microRNA signatures that do identify people that are fast progressors or slow progressors. So I do believe we are now living interesting times where new biomarkers are coming out, demonstrating indeed that heterogeneity is there in T1D, specifically when it comes to the speed of destruction of functional beta cell mass. Are they immune biomarkers? Are they beta cell biomarkers? Probably both. So we are getting there, and our brains are too small, so we do need artificial intelligence to help us with these analyses, but we will get it. I do think we will rapidly evolve to tools that tell us you will evolve rapidly, you will evolve slowly, and the same is true for complications and what have you. Also there we do have biomarkers.
So when we think about therapy, I'd like to hear Michael Rickel's view on how do you consider heterogeneity when you think about islet transplantation?
So that's a great question, Henrik. So I think and Jeff alluded to this, currently there's a very homogeneous group of patients who qualify with many years of type 1 diabetes and complicated with recurrent severe hypoglycemic events. And as we think about expanding cell therapy to a larger population of individuals with type 1 diabetes, we have to think about many of the other issues that have been talked about today, age of onset, duration of disease, as well as body size and ancestry background, and then also the way they've gotten there. And I think what we're going to learn is that reactivation of the immune system and recurrent autoimmunity has to be likely individualized in terms of how we approach therapy. And so I don't think there'll be a one-size-fits-all with the immune therapies that are required, and whether that's engineering of the cell product and or novel immune approaches that are being developed that have less burden of toxic immunosuppression, such as calcineurin inhibitors, but target certain pathways that we need, again, to the biomarkers. What immune pathways are active in the patient in front of you, and how can we target or tailor an immune supportive therapy that best fits their underlying disease?
Thank you very much. And I think we have time for one last question from the right here.
So, Henrik, thank you, and Stephen and David for putting this session together. It has been my favorite at this ADA meeting, but then again, I say that at every session. It's my favorite. So anyway, you have 9 people on this stage here. I would like to hear from them in 3 to 4 sentences each, not 3 to 4 minutes each, 3 to 4 sentences each, with these great questions. What would you target and why? 3 to 4 sentences each. If you can start with left here with Mike and then go across so everybody can speak. What would you invest in and why? Just quick answers, please.
So I would invest in understanding this single autoantibody individual who develops type 1 diabetes. What are the markers that are required to understand those individuals who we know to progress because we diagnose them with type 1 diabetes, yet don't fit in the current staging model that we have for type 1 diabetes?
I would invest in multi-omics. We have computers full of analysis now of immunomics, metabolomics, proteomics, blah, 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 omics. Put supercomputers on them. There are signatures that will be applicable, I believe, to really stratify people for risk, stratify people for therapeutic response or therapeutic resistance. And that will help us finally prevent or cure T1D.
Well, since I talked about cell therapy so much, I'll give a different answer, which is to use this amazing AI computational infrastructure, but instead use it to focus on patient-derived iPS cells. The last slide that I showed in my presentation, that if we can, right now we're really only studying one patient or two patients at a time or a gene at a time here or there. But if we take a very concentrated effort to generate, 1,000 lines, 10,000 lines, I don't know what you actually need there, to that represents the heterogeneity of type 1 diabetes, and then throw every single hypothesis that we have at it and have all these amazing AI overlords go and look at the data and give us the answer, I think that could, leap forward our understanding of type 1 diabetes by 30 years.
So, I tend to agree with Chantal. I think I would probably, when you think of biomarkers, it's not just defining the heterogeneity of disease pathophysiology, but also the heterogeneity of response to treatment. And so I think that if we gathered that kind of information, multi-omics information, it can actually be really illuminating just in terms of not just the disease and how it's different in people, but also how different people respond to therapy. So I think that's really where the money is. This is a heterogeneity session, so I think we need to figure this out.
I would screen. You need to screen not just children, you need to start screening adults. I would invest, as has been said, in biomarkers and in combination therapies.
Okay, I would partner with David to take all the people that he screens, and I would focus on the stage 1 population, because I think we know very little about how to intervene in this particular population, and there are so many challenges associated with timing things to disease progression or the development of stage 3 type 1 diabetes. So I would invest in very, very large multi-arm screening platform where we could test agents in a rapid fashion using intermediate endpoints, and then take the winners and put them into fully powered trials. And then I would also invest in longer-term follow-up of the people that we put into stage 3 trials so that we can push for registration of therapeutics in that arena.
Okay, so I would invest in incorporating the wealth of knowledge that we have on genetics of type 1 diabetes into clinical practice, so that we can use that knowledge to classify diabetes, which I think that we still need to do that, and to predict progression to type 1 diabetes, and select those who will respond to the therapies that we have, which is different than predicting type 1 diabetes. And I would also invest in tools that would allow the clinician and the clinical researcher take that information, not only genetics, but incorporating metabolic measures and in antibodies and other things in a way that can be actually used. Because I think that at this point, antipilizumab has shown that the approval that we are unprepared. And I think that the clinical researcher and the clinicians need to be able to use that information.
So I guess surprising mark, which will be pretty easy. I would actually invest. Yeah, okay. But I would actually invest in implementation science. And basically, we have a lot of information we're gathering, we'll gather more. But unless you can figure out how you can get people to actually do the testing and get testing done in an inexpensive way, rather than putting clinical coordinators in every pediatric waiting room in the country or world, I think you have to figure out how you're going to get the information or to testing to the individuals and then get the individuals to actually do the test so that information comes back and you can determine who is at risk that can then enter into those characteristic trials or therapies.
Yeah, I mean, I can just echo all the other panel participants, but I think another very important aspect here is to think about how we get this understanding of heterogeneity into clinical practice. I think, I mean, it's very important we kind of make sure that this is not, in quotation mark, an interesting academic discussion, but it actually has some impact on how the patients or the coming patients actually will fare. So, and for that, I mean, we need what has been said here. We need biomarkers. We need to be better to identify responders, non-responders to different treatments. We have to look into combination treatments, et cetera, et cetera, et cetera.
So on those wise words, we will end the session, and I will again extend my gratitude to the Novo Nordisk Foundation that has funded these activities, and to all the participants behind the scenes. Debbie Kendall, Chris Kohler, and Judy Naylor have helped organize. Thank you very much.